Okay, we'll cut this out later. Hello, good evening for people in Syria and Arab world. Good afternoon for our friends in South America. Have a good day all over the world. I'm Professor Dr. Nabil Kochaji. I'm with you for this quick lecture, and I thank Amolka for invitation to be with you tonight to say something about how to gain full capacity in clinical oral pathology. The main problem is dentist thinks that pathology, histology, general histology, oral maxillofacial histology, oral maxillofacial pathology, all these subjects that they studied previously in dental school, they think that these subjects are a microscope only, and it's not the case. If we want to go philosophically, pathology means a lot, not only histological fields. It means clinical data, epidemiology, clinical manifestation, radiographical manifestations, blood test, and histological analysis. Let's start. That's something written in Spanish for me from Amolka. I re-thank them. That's my latest book. I was very pleased to see the Spanish edition. It was really luxury, very nice translated, very nice printed, and very nice distributed. And let's start. How to apply oral pathology in real clinical scenarios. Let's go directly to the scenarios. What you see here is a patient with white patches all over the maxilla, the upper right jaw, and the second area, and we have to have a biopsy to know exactly that it's lichen planus, and that's something very nice. Go on, move on. Life is easy. The problem is, my friend who took the biopsy said there is thickness in the cheek, and there is something not nice in the case. And moreover, radiographically, the root of the upper molar is flying outside the cortical bone in this site here, and that's something doesn't match with normal oral lichen planus. Now we have to gain our full capacity. Lichen planus is not only a disease, not a one disease. There is variants. There is the erosion, there is the conventional, and so on and so on and so on. And when oral lichen planus destroy the cortical bone, that's a red flag. That's a bad sign that we have to know that the patient underwent, after 3 years from the previous biopsy, and because of bad treatment, he developed squamous cell carcinoma, and he came back to my lab in this way. And instead of having one page, we have several sections, several histological fields, and finally he was diagnosed squamous cell carcinoma grade 2 from a previously described lichen planus lesion. All surgical margins are free of malignant invasion, lymph nodes are free, no vascular invasion, no perineural invasion. Still, all studied oral mucosa and cheek mucosa suffered from moderate to severe dysplasia. Oh my God, what happened? Well, in fact, what happened is that the patient and the dentist thought lichen planus, it's nice, it's benign, it's nothing. No, it's a big thing. And he went to a dermatologist who gave him several points of treatment. One of them is nitric cryotherapy, and that was the conclusion. Let's look to another thing. This lady came to her dentist saying, I have abscess, and because dentist knows that abscess is either treated endodontically or extraction, he extracted very easily, and it was nice to be extracted. There was no radiographs But after a few years, she came with a swelling, and on radiograph there was something not nice. There is a lesion here, and this lesion is not well demarcated. The borders are not clear. It's not radiolucent. It's not radio opaque. Even you can say it's mixed. There is something inside. The bone is destroyed inside the jaw of this lady. And again, the first incisional biopsy, it was a Bindborg tumor, classified odontogenic tumor. And because we know as oral maxillofacial pathologist, because oral maxillofacial surgeon knows, and because you should know as a dentist, Bindborg tumor is an aggressive, really aggressive tumor. And this lady lost big part of her maxilla for the same diagnosis, but the final diagnosis was there is free surgical margins. Again, what happened? What happened is that dentist does not use his full capacity to see radiographs, to link them to the clinical manifestations, and that's the result. The follow-up of the lady was nice, and now she has a full arc of beautiful teeth, but they are not really real, they are implants. A third case, this model, she was very lovely, very young, and she asked me personally, Dr. Nabil, I have something in my palate. Told her, since when? She told me, since I made a plastic surgery for my nose. You were at a doctor office and he didn't recognize that? Well, I showed it to him and he told me it's nothing because the tube that we entered through the operation, there was some irritation in the area. That's all. Well, was there any radiographs? Yes, I made my own radiograph. That's it. I photoed with my mobile phone. These are my nails. Well, poor lady, poor young girl. What's that? Well, as you see, where's my mouse? Okay. As you see, in the left maxilla, there is no sinus. In the right maxilla, there is a sinus. That's a big bad sign. The mass is in the left palate, and in the same area, the sinus is destroyed. Incisional biopsy. Bad news. Adenoid cystic carcinoma for young lady. This adenoid cystic carcinoma, a solid type, needs a lot of going on research. On PET scan, hopefully, there was only one spot of the lesion. Surgical report, and the poor young lady came to the lab as 24 samples. And again, we have plenty of sections, and this time the adenoid cystic carcinoma solid type has no cervical lymph node invasion and free resection margins. Now, we need to improve our diagnosis. We need to improve the patient care. We need to know to use the knowledge that we already have. Let's start. If I want to best practicing oral biopsies and lesions, I will take some examples. Again, in the left maxilla, this time with a man, you see his hard palate, there is something. On radiographs, well, there is not that big deal of manifestations. Well, let's see what's going on. General dentist took a biopsy to a general pathologist. That's something annoying. You have to know that we are dentists. We have our own surgeon, oral maxillofacial surgery, or oral surgeons. We have our own pathologist, oral maxillofacial pathologist. General pathology is for general doctor. Anyhow, not for dentist at all. The diagnosis was a mass in the hard palate, presence of hyperplastic squamous mucosa without a tibia. Well, but I see, as a dentist before being a pathologist, there is a mass, and hyperplastic squamous mucosa may not be seen as a mass. There is a problem with this pathological report. Anyhow, the dentist took it as a Bible, and it says hyperplastic squamous mucosa, there is nothing, there is no atibia, go on. And he went on, start making bridges. But here I can see that there is a problem in radiograph. Well, let's move on. That was the beginning. We have bridges now, but if you see, the bone is being lost, and that's really a bad sign. Another biopsy, this time from oral surgeon, this time to oral maxillofacial pathologist, this time it turned to be, the mass turned to be squamous cell carcinoma grade 2. Oops, but we had a pathological report. Yes, you are, as a dentist, the first line of defense if the pathological report was wrong. You have to read it fully. You have to read it point by point. It's not a newspaper to go to the conclusion only. To say, okay, what happened last time? This football team win. No, no, no. You have to read all the news till you have the conclusion. And if the conclusion is not well accompanied with the clinical things that you have in your clinic, you can and you may and you must say, this pathological report is not good. I need a new advice. I need a new pathological report. Same patient. Same patient. Same patient. Okay, looks that I missed something. I'll go back here. Well, that's me, that's your friend Nabil, and that's the operating room in my lab. And let's see that poor patient sample. That's the bridge. You saw it already, and now it's in my hands. That's part of the jaw, part of the maxilla of the patient. And you know, normally bridge is made over teeth. They are located in a socket in alveolar bone, meaning I cannot, with bare hands, without scalp, without elevator, without anything, without any tool, I may not take it off with my bare hands. But I can do it, because very simply, unfortunately, this is not any longer alveolar bone. This is mass of squamous cell carcinoma. Okay, free surgical margins. Now let's inspire the new book. Communication between oral surgeon and oral pathologist. Normally there is surgery and there should be surgical report. There is pathology and there should be pathological report. Is it a puzzle? What do I need? I need something written. Okay, whether in Arabic, in English, in Spanish, whatsoever. I need the name of the patient, his age, the location, and so on. And I need the biopsy. Is that all? Is that all? Is that all? No, I need moreover some radiographs. You have to show the pathologist all the things that you saw, clinically, radiographically, if there is blood test. You have to write well documented things. This is the the surgical report that I really like. It's my own. I'll ask the friends in Amolka to distribute it to you, to give it to you. Let's go into details. Patient information, patient name, date of birth, gender, phone number, the lesion information, soft tissue lesion, color, size, swelling, ulcer, duration. By the way, if you have the chance to have the book in your hands, you will see it in Spanish between your hands. with all details. Why do we need each section of this surgical report? If is it intraosseous lesion, the size, is it solid or cystic, is it radiolucent, radiopaque, or mixed, the duration of the lesion, what kind of X-ray that you used, is it plain X-ray, normal X-ray, sensors, panorama, or it is CT or CBC or MRI. What type of biopsy did you use? Do you have incisional or excisional? And what was your transporting medium? That's a huge thing to talk about it. Do not use normal saline as a medium to transport. At least use alcohol. The lesion history, your clinical impression. What are you seeing, my dearest doctor? What are you seeing? What do you think? Do you think it's an abscess, radicular cyst, dentigerous cyst, odontogenic keratocyst? What do you think? Date of performing the biopsy and your telephone number. And if we want to go on, go to the other side of the page of the paper of the surgical report and mark, please. Is it on the cheek, on the large cheek? Is it on the panorama? Where it is on the panorama? Is it under the tongue, above the tongue, in the hard palate, on the nose, on the lip? It's our area. Detailed surgical report might be very nice to have it point by point. Well, otherwise, you have to write a lot to tell me what happened to this poor patient to come. This is a live human. He is still kicking and alive till now, but he came to the patient, to the lab like this, unfortunately. Now let's go to some cases to apply our new knowledge. What do you see? What you see is radiolucent lesions, okay, all over the panoramic view. Okay, there is a mass here. Well, not a mass, it's just a swelling. Don't over exaggerate. Swelling, radiolucency, biopsy, incisional biopsy or excisional biopsy, doesn't matter, and it turned to be radicular cyst. Perfect. So we know it's radicular cyst because it's dead teeth, because there is abscess, because there is radiolucent lesion, because there is how to say it? Oh, the case is talking. I am radicular cyst. Well, let's go on. Another case, this time also in the upper jaw. This time it's in the sinus, and the same thing, non-vital teeth, mass, radiolucent lesion with cystic thing in the sinus, and incisional biopsy this time. And before going to show you what was the final diagnosis, I have to tell you I did a mistake less than 1 minute ago. I said there is a cystic lesion in the sinus. Who said that any human being can see from 2-dimension radiograph a 3-dimensional thing like a cyst? Normally we see radio opacity of the impression of the lesion in the sinus, because the sinus is normally black because it's air. Oops, let's go back. But it's non-vital teeth with a mass, just like the first case, and I see the cyst in the sinus. No sir, it's not a cyst, it's a lesion. This is 2-dimensional image. And let's go to our incisional biopsy and let's see what happened really. And it was adenomatoid odontogenic tumor. It was a tumor, it was a mass, it was not even a cystic lesion. Let's go to the third one, and it's a bit annoying. Vital teeth. Vital teeth, meaning there is no periapical granuloma, for sure. There is no radicular cyst, for sure. And the patient is young, in his 20s. And you see on serial sections that there is something wrong in the bone. And there was an incisional biopsy, and on the surgical report there was a mark, a very annoying red flag, bad sign mark. It says there is some neurological features and signs in the lip and the tongue, and that means this lesion is attacking the nerve, and that's not a sign of a benign lesion. It's a very bad sign, and you should think about malignancy. Well, it was a very small biopsy, and we ended with this conclusion. The differential diagnosis of the surgical biopsy includes osteosarcoma. It's very small. We cannot be sharp enough to say it's osteosarcoma. We need either to have a bigger biopsy or to apply immunohistochemistry. But you know what happened? The patient refused the news. I am a young man. I'm 20 years old. I do not have malignancy in my bone. I do not have cancer. I have nothing. I'm very well. Please, you have a pathological report in your hand. You may have another advice. He went to several labs. First lab said there is signs of malignancy, but I'm not sure what type of things. Second one, third one, fourth one, fifth one, and he kept on moving till he reached a lab saying, I didn't see any malignancy. There's fibrous tissue showing acute and chronic inflammation with granulation tissue. No neoplastic changes are seen. And the other side, another histological field, there is fibrous tissue with acute and chronic inflammation, and there is no neoplastic changes. And the patient has now two news. First of all, sarcoma, one hand. On another hand, inflammation. And he made an election, and the inflammation won. And he was very happy. You know what happened? He went home and he never showed up to any dental surgeon at all, even though we know as dentists that this radiographical appearance, this destruction of bone is not normal, even though we know that we have several pathological reports saying it's malignancy, it's sarcoma. We are not very sure of what type of sarcoma, but there is a catastrophe here. The patient went home. That was almost a year and a half from now. Nobody knows what happened to the man. But what I'm sure of, that I have a similar case where the patient refused completely what the doctor said to him, that he has cancer, and the poor patient came first time with incisional biopsy, second time with half jaw biopsy. You know, it's sad stories, what I'm saying, but all of these stories are not as sad as the coming one. Unfortunately, you see this, there is something here, something. I don't say it's cyst, I don't say it's mass. There is something in the jaw. And this radiograph belongs to one of my students. He was my student, then he became my colleague. He's a dentist. This poor dentist a few years ago had a third molar with a cyst on it. Who says it's cyst? They saw the panorama and they saw unicular radiolucency over the third molar, and they said that's a dentigerous cyst, and they extracted the third molar, enucleated the dentigerous cyst, sent it to the trash, saying, good doctor, good friend, there is nothing here. And it reoccurred, and it reoccurred, and it was enucleated till his father bring the jaw of the dentist to my lab. I went to the hospital and saw him. I know him. He's one of my students. but I didn't know that he has something terrible in his jaw. And even he didn't know, because what he heard from the oral surgeon, it's a dangerous cyst. You should know a lot of these cases, who your friend, your next door surgeon, your colleague, saying on radiographs, he looks at the radiographs, your patient has a dangerous cyst. That's two-dimensional image, my doctor, and you may not say it's a dangerous cyst. We made serial sections, and it turned to be mural cystic ameloblastoma. And we know, and you should know if you don't know, that ameloblastoma is not one lesion, it's not one disease. Ameloblastoma is either unicystic or multicystic, or we call it solid. And the unicystic has 3 categories. The worst of them is mural, and you should know that solid or multicystic ameloblastoma is not one disease. It's divided into follicular and plexiform. And follicular is not one disease, it's divided to subcategories. And you should know that because each category has to be performed in another way of surgery. They are not one disease. Mural cystic ameloblastoma, the surgeon should be aggressive from the first time. Otherwise, my friend, my colleague, my dentist, my student wouldn't lose his jaw. It's really sad for me, and the saddest thing is this. I will show it very clearly. By serial sectioning, an odontogenic cystic lining was detected. It's the traces of previous dangerous cyst in the area that had an ameloblastic transformation. We had another scenario now. There wasn't a dangerous cyst. The surgeon who took off the 3rd molar and said this is dangerous cyst was correct. It was a dangerous cyst. But, a big but, dangerous cyst has the ability to transform into ameloblastoma. If at that time it went to an oral maxillofacial pathologist and made serial sections till he saw the dangerous cyst, section, and the ameloblastic transformation in the dangerous cyst, at the time, he should know that we have to have a bit aggressive surgery to curettage the bone here well, and to follow up for a long time before the lesion reoccur, because it's not anymore dangerous cyst, it's a transformed dangerous cyst, it's a transformed to ameloblastoma, and this ameloblastoma is going to grow up and it's going to be turning into mural ameloblastoma and destroying the jaw. That's really the sad story upon all the stories that I told you. Let's go to have treasures and benefits. I told you about patient who denies, and I told you about radicular cyst who was sent to the trash because it's obvious it's radicular cyst. Radiolucent lesion is not always radicular cyst. It might be much worse. A white lesion is not always a thrush or fungal infection. You should think more logic. Biopsy is not luxury. You should think about learning how and when to perform it. It's the patient right to see and look for another consultation. The doctor's duty is to guide him. You see these 5 benefits? These are the ultimate thing that I gained through quarter of century, 25 years of working with oral maxillofacial pathology. I wrote them down one by one. Each line I got it from a case, an unfortunate case, a sad case, a bad case. I wrote one line, another line, another line, till I made benefits, almost 100 benefits in the book. These 100 benefits, these scenarios are redocumented to see what was the problem here. Well, I'll document the problem. I'll tell how to go out of it one by one, till we have the guide, the complete guide. In the patient life, the cancer patient life, there is 5 steps after diagnosis. First of all, he will deny, saying, no, I do not have cancer. Second, he's going to doubt of the diagnosis. It might be that this pathological report is wrong. I think I have to have another consultation. I should go to another pathologist. It's most probably wrong. Afterwards, it turned to be cancer. He's going to say, why God? Why me? I'm a good man. I'm a nice man. Why do I have it? Fourth stage. I know it's true and I want to have treatment. Number 5, cure. Now you think, well, cancer cure? Yes. All cancers of head and neck may cure, may heal, patient may survive, may, if, and only if, he passed through the first steps, denying, doubting, and doubting very fastly, very rapidly. So, as a family, as a medical family, we have to guide our patient very strict, very directly, and as fast as possible. From diagnosis, from good diagnosis, from ultimate diagnosis, using all our clinical pathological knowledge, in one case, apply it, and guide him directly through the first 3 steps to treatment, and treatment in your hands. In 2020, I translated this book, Counsel Essential of Oral Pathology and Oral Medicine. In 2019, I wrote 1 chapter in this book, Contemporary Oral Medicine, among other, with 2 of my best friends. In 24, I added all my knowledge to this clinical pathology, this book, Clinical Oral Pathology, Kochaji Guide to Oral Lesions and Biopsy. By the way, all of the cases in this book are intraosseous. In 2025, I was very pleased that Amolka took this English textbook from Springer and translated into Spanish and published it. Now I sent Springer my 2nd edition of Clinical Oral Pathology, this time to oral mucosa. And thank you very much. I'm all ears to hear from you. Thank you.